Hello and welcome to another episode of the Life After Cardiac Arrest podcast with me, your host, Paul Swindell. Okay, today I'm speaking with Dr Katie Dainty, who's a research scientist in the medical field. You've got a big long list of jobs that you've done and positions that you hold at the moment. Could you tell me a little bit about those? And welcome, Katie.
Thank you very much, Paul. Sure. So I hold a research chair in patient-centered outcomes at North York General Hospital. And I'm also an assistant professor at the University of Toronto in our health management policy and evaluation faculty. So we do a lot of applied health research about systems and patient outcomes and how we can measure what we do in the healthcare system in a way that reflects what's important to patients.
And this is just covering Toronto, is it? Or does it cover the whole of the Canada, what you do?
Yeah, so I'm also part of the Canadian Resuscitation Outcomes Consortium. And so most of my work is actually across Canada and international as well. But my positions are just within Toronto.
And I understand that a couple of your major research projects are understanding survivorship following sudden cardiac arrest, patient and family perspectives on life after death, and the Bystander Support Network, which is what I particularly want to speak to you about. But could you tell me a little bit more about the understanding survivorship following sudden cardiac arrest? What's that about?
Sure. So I became really interested. I'm a qualitative social scientist by training. And so that's what my PhD is in. And I became very interested in what happens to survivors of cardiac arrest and their families after they get discharged from hospital. I've worked in the resuscitation field for quite a number of years, and I really noticed that we weren't paying much attention to that life after type journey. And so, and that really is very qualitative in nature. And everyone's is very different. Everybody's journey is very different. And so I've been working now for about the last 5 years with survivors and family members to help understand what that's about and use that information to hopefully improve the interventions that we can use in the healthcare field to help patients and families, make that journey a bit better, a bit easier. And the Bystander Network sort of is part of that as well. So I also became very interested in what happens to people who respond to cardiac arrest. So those who give CPR at the scene, who may be strangers, they may be family members. It depends where the cardiac arrest occurs. But they also I always like to say that the ambulance comes along and picks up the patient and potentially the family, and then the bystander is sort of left there wondering what just happened, and not really getting much follow up or information after that. So we created the Bystander Network as a virtual resource for people who respond to cardiac arrest as a way to get some trusted information, and we're hoping that it can start to be a bit more interactive, and we might be able to start to form some groups and in-person type things as well, because everyone, whether you're a survivor, a family member, or a bystander, needs support after cardiac arrest. It's a fairly traumatic event, and we haven't done much to support people, and so that's my area of interest.
Well, it sounds very laudable what you've been doing, and what had you been experiencing? What initially, when you started looking at it 5 years ago, what did you think about the life afterwards bit, the post-discharge care? What was being done in Canada at that time?
Yeah. So in Canada, and I'm a little bit familiar with some of the international care as well, but not as familiar as with Canada, of course. But in Canada, it's very variable. Some patients go to cardiac rehab, a certain percentage. Some patients do get followed by a cardiologist, particularly obviously if they get a defibrillator implanted, the shock, the thing that gives your heart a shock if you need it. And then some people are just discharged to go home because they're quote unquote normal. They score normal on all of the neuro scales. and their heart is recovering and their brain is fine, apparently, according to clinical tests. And so off they go. But what I quickly learned is that then everything else comes into play. So, obviously, and you know this better than anyone, Paul, as a survivor yourself, but fatigue, concern, anxiety, wondering what you should do with this new life you have, changes in relationships sometimes. Some people are very empowered. Some people are very disempowered. And so there's a lot going on there. And so this is something that I don't think prior to about 5 years ago, there was much attention to. And even if you talk to some of the clinical folks, cardiologists and people like that, they'll say, well, they're fine. Their heart is fine. They can go on and do it, whatever they want. But there's a psychosocial piece to it that is huge, that we really need to work with patients and family survivors and families to understand better. And on the flip side, the bystanders, it's the same thing. We think people can walk away from saving someone's life without, any thought to it. And yet people lose sleep. They also develop depression and anxiety about what happened. Again, sometimes they're empowered and sometimes they're disempowered. And how we can develop support tools for people in both situations is become very apparent to me that it's very needed.
Mm-hmm. It sounds very similar to the UK, and probably, as I said, you got experience worldwide as well. Is that your understanding how it is most countries or most developed countries?
Yeah, I think from my great colleagues around the world, I understand that it's pretty similar. Whether it be the UK or the United States, developed countries, as you say.
Why is it, do you think, that it's just it's just about now or the last few years that people are starting to look into that aspect of the scenario?
Yeah, I think probably because certainly in Canada, there is great fractures or gaps in the care systems. So we have pre-hospital care, we have hospital care, and then we have community care. And sort of they all operate very separately. And so once once in the pre-hospital setting with the ambulance and the EMS services, they take care of you and then they bring you to the hospital. And then never do the pre-hospital folks find out what happened in the hospital. So very rarely are we able to share the survival stories with the pre-hospital folks. And then you get taken care of very well in the hospital. And then we discharge you, and then we put you out the door, and we don't talk about what happens to you after that system. And so I think that that trajectory is quite stilted. And there's an expectation by each phase of that system that the other one's just going to pick up and take care. But that isn't always the case. And particularly in Canada, the community system, once you're discharged, is very overloaded and very under-resourced. And so usually patients and survivors and family members have to seek out their own care in that system. And that can be very overwhelming when you've been just discharged from the intensive care unit. And so I think the problem is that there was each system didn't know what it didn't know about what was happening on the other side.
Uh-huh. It sounds similar in some ways to the UK, but I mean, we've got the NHS, I'm sure you're aware of it. Is there a similar concept in Canada?
It is similar. So we have a single payer system as well. But it is, I think, and you can correct me about the NHS system, but I think Ontario is starting to move to something more similar to the NHS, where within a trust, there are several pieces of the healthcare system. Is that correct? So like a hospital and a community care system might be partnered together.
Yeah, I think so. I mean, I don't really know much about the workings, but I know there are trusts around the country. Yeah.
I think that's kind of how that works. And so in those situations, I think they can work quite well because they're more closely aligned or working together. Until we get there, we're moving to something like that. But right now, we have a single system. I always say that that's a bit of a misnomer because it's not actually a system. It doesn't work. It doesn't function like a system. So I'm sure maybe people in the UK would say the same about the NHS.
For a couple of stats, what's the population of Canada, and how many out of hospital cardiac arrests are experienced there? Do you know?
Right. Yeah. So we have 40,000 cardiac arrests a year in Canada, and our survival rate, it runs between 10 and 15%.
Oh wow, that's pretty decent then.
Yeah, it's not bad. It's it's lower in some, average. It's lower in some places and higher in others. We haven't quite hit the Seattle numbers of 30%, but yeah. So that's on average we have about 40,000 a year.
Uh-huh. I mean, in the UK, I'm sure you're probably aware, so it's below 10%. It's about 8.6. The last official figure I think I saw was from 2014. It might have gone up. They're making a push to push it upwards, but with CPR mandatory in schools now.
That's wonderful.
Well, I think it's this year or might be next year. But yeah, it's good. But it sort of does bring us back to the what the topic was about: people giving, or lay people giving CPR, and the repercussions of that. You talked about your bystander CPR network. Could you just sort of tell me how it came about and what it does?
Sure. So, as I was saying, one of the things that was always of interest to me as well is that there's always a big push, and you just mentioned about a big push for training more people to do CPR, and that's a wonderful thing. Everyone having even a little bit of training, even 5 minutes of training is important because it increases confidence. But to ask people, to call people to action in that kind of situation, particularly strangers, or even it's sort of different if you're a stranger versus if your spouse or your brother or your sister, drops of a cardiac arrest. To call someone to action to save someone's life is a very big deal. And so while we take people and we train them, maybe they go for 4 hours or something like that, and they do some course on a mannequin in a temperature controlled room, on a mannequin that's lying on the floor that is perfectly clean and doesn't have any breasts or any doesn't have hockey equipment on, or whatever the case may be. I think over the years we've done a bit of a disservice, and I say that with all due respect, because certainly CPR training is very, very important, and many people have worked very, very hard to bring it to where it is today. But I think that we need to evolve it in the sense that it doesn't really represent real life very well. And what sometimes happens is that we train people, but we don't train them for what's actually going to happen. And on the other side, we don't train them for how they're going to feel, or we don't talk about in training how they're going to feel afterwards.
Are you saying it's all a little bit clinical, really? It's not. It's all, as you say, it's all nice and clean, and you've just got a dummy. I mean, what do you think should be done then to make it a little bit more perhaps realistic?
Yeah, I mean, I think there's lots of things you could do. You could make more realistic type mannequin situations, sitting them inside of a stall in a bathroom, or in an airplane seat or in a chair, and then having to move them down. I mean, what mostly causes people to not want to respond is those kinds of situations. And so we know from other fields like sports and coaching and even in business, the more normal a situation seems, the more you'll sort of get that muscle memory, so to speak, about being able to react, and it won't seem as scary. I mean, even the situation where when someone has had a cardiac arrest and they're quote unquote not breathing, we know that they actually do this thing called agonal breathing, which makes them kind of go kind of like that. It's almost like a gasp. And so that can be mistaken for breathing quite often. And we don't really talk about that at all in the courses. People may mention that people will be doing agonal breathing, but we don't teach people how to recognize that as actually not breathing. And so some new research is coming out to show that many times the reason that CPR isn't enacted more quickly is because people didn't recognize right away that it was a cardiac arrest. And so things like that are really important. Even sometimes people will foam at the mouth sometimes when they've had a cardiac arrest, or they may even vomit. I'm not sure if we want to put vomit on the mannequins, but those kinds of things. Even like I mentioned, things like breasts. Some people are very worried about giving. There's actually been research by a colleague of mine, Audrey Bloor at Duke, that showed that women get significantly less CPR than men, and our hypothesis is because of the intimacy of it. And we've moved away. One of the big changes, I think, which is huge, is that the guidelines now do not recommend mouth-to-mouth in adults. So it's chest compression only CPR is recommended. And that's huge, because one of the big barriers we used to hear about was this idea of mouth-to-mouth and doing that in a stranger situation. Mm-hmm. So I think removing that has helped a lot to encourage people to be able to pound as hard and fast as you can on the chest. That seems a bit easier to do than to actually put your mouth on someone else's mouth. And so those kinds of things. Other colleagues of mine are doing some great work with virtual reality and some of that kind of training, which puts you into a real life scenario and gives you that, heart pounding kind of feeling so that you can learn to react in that situation. So just a few things that I think we could do to make it a bit more realistic.
Yeah, that sounds some great ideas there. I like the virtual reality one. And there's I don't know, I think it's the Resus Council in the UK have got a website. I'm not sure if it's virtual reality, but it's a film that you control as you go along, and you make decisions, and the characters do different things depending on what you say and how you react. That could, I would imagine, be extended into actually having some sort of 3D or not 3D. You actually been linked into a Resus Annie somehow. But yeah, that's where the future is going, hopefully. But also, I was really interested to hear the fact that you said that they don't really talk about or don't explain or demonstrate what agonal breathing is, because that's, like you say, is quite key.
Yeah. And they may mention it, but to actually, even to, there are mannequins which are very, very high end, which have a lot of computer animation and things in them. Obviously, the average CPR class doesn't have those kinds of mannequins, but even a tape recording of agonal breathing doesn't, to my knowledge, doesn't ever get played, so that you can hear that noise and appreciate. Whether or not you remember it in the situation is another story, but just something people aren't familiar with. And I know that when we talk about dispatcher assisted CPR, another thing that's really helped with encouraging people to do bystander CPR is that when you call 911, or what's the equivalent in the UK?
999.
999, and you get a dispatcher on the phone. This is almost worldwide now. The dispatcher will coach you in providing bystander CPR, and that has been so helpful. But one of the things they're really struggling with is when they say some of the first initial questions they ask is the person breathing? Mm-hmm. And if you're gasping and I say yes, the dispatcher doesn't immediately jump into giving you CPR instructions. So there's a delay. And so that's something we really need to work on fixing.
Yes. On my website, or the Sudden Cardiac Arrest UK website, I've actually got a page on agonal breathing, which is got a couple of it's got a description about it, but it's also got 2 videos. One's a cartoon. It's not any real agonal breathing, thankfully. Yeah. And someone doing a very good demonstration of it, actually, an actor simulating it. And if anyone wants to go and have a look at that, do. It's actually strange. When I first put it up, I didn't realise how popular that page is going to be. It's quite surprising, actually. But
terrific.
Yeah,
I think people just, it's people just need to see it, to hear it, to feel it, and it's the same sort of thing. And I think that it will never replace the sort of traumatic situation that you're in. We can never sort of replicate that per se. But I think this kind of vanilla, cleansed antiseptic kind of training that we're doing needs to change. And I also often say that, as I say, training is important, and I think everyone should get it. But I think a mistake that we made, 30 years ago plus, was making people think that they have to be a card-carrying member with some kind of official thing that says that they're able to do CPR. We often see that is that people don't want to get down and help because they don't, even if they have or have not been trained, they don't think they know what they're doing. A lot of people still feel it's a very medicalized act, and that only health professionals can do it. And so there's a lot of misconceptions around it, and really anyone can get down and push hard and fast. That's my cocktail party line, is that anyone can get down. My 7-year-old daughter can do CPR, and so anything that the person is dead, and so anything you do improves their chances of coming back. Absolutely. If you do nothing, it's 100% chance they will not come back. So it's that kind of, I think, encouragement that we have to give people to empower them to be able to do CPR and to not be afraid of what might happen. And that's sort of what the Bystander Support Network is about, is providing people that kind of information. The information that's on our website was created by the steering committee that I work with, which is largely bystanders and survivors and family members of cardiac arrest. And so we tried to word the information in such a way that it's accessible and that it makes sense of the kinds of questions that we hear, instead of just being, sort of like a textbook. A bit more like, why was the person blue? And can I hurt them? What happens if I break their rib? Can I be sued? That kind of information, to try and give people a sense that it's okay. You need to get down and help, and you will not get in trouble or hurt the person if you do.
Yeah, absolutely. Just sort of dispelling some myths and giving some sort of, I don't know, safety factors or feel good comfort factors that they're not going to do any damage because they say, I'm not trained to do it, and it's going to be these events are very, well, as we've already said, are very traumatic and scary situations, and I don't think many people actually step in, do they? Do you know what the sort of rates for bystander CPR is?
Yeah, the sort of standard quote that we give is it's only about 35% of the time.
So it's quite low, really, isn't it?
That's across all cardiac arrests, so not just ones that happen in the home, because actually 75% of cardiac arrests happen in the home. Only 25%, and those are rough numbers, happen in public. And so even I just spoke with a woman the other day whose husband, she was running late. She happened to be home. He came out of the shower, walked into the bedroom and collapsed. And she ran out and went and got their neighbor. And rather than walking over or, going over to him and starting CPR, because she didn't think she could do it. Uh-huh. And we know that for every minute that CPR is not started, you lose a 10% chance of surviving.
Indeed.
So it's crucial that it starts right away. And that anybody gets down and starts pumping on the chest.
You said the rate is 35% across in home and outside of home. Do you know, is there a difference between are strangers less or more likely to do CPR than someone you know?
It's about the same. Okay. Yeah, there's not a great difference that you would think. I think that sometimes because we see that. In some cases, as particularly in the cases of the elderly, the spouse is of the same age usually, and sometimes that's problematic because just from a perspective of being able to actually physically do the CPR, and then in the public setting, it depends on the situation. So it's and in today's day and age. I think people, sometimes I say I feel badly that people are more likely to pull out their cell phone and video the guy lying on the ground than they are to actually go over and see if he's okay.
Yeah, it's true.
And so I don't mean to make such a negative statement about society, but it seems to be the way. So it's the same, but for different reasons.
So on your going back to your bystander network, what was the URL, the address of that? If anyone.
Yeah, so it's bystandernetwork.org.
And is that just for Canadian citizens or Toronto citizens?
No, it's meant to be. It was developed in Canada, but it's meant to be universal.
Okay, cool. And so is there what do you have to join it, or what is the publicly available?
Yeah, so everything is publicly available. You can look at the whole site without joining, but there's also an opportunity for you to submit your name and email address to receive information. And to every once in a while we send out sort of newsletter type things, or we also sometimes send out opportunities to participate in research, which of course are completely voluntary, but just notices about research projects people might want to get involved in.
Uh-huh. And you mentioned to me before that you're going to be conducting one quite soon.
Yes. So one of the things that we have in common is an interest in the use of social media, and for both survivors and their family members, as well as bystanders. And so looking at how people use social media to connect with peer groups and people like themselves to share information.
Uh-huh. Is this something that's used within the Canadian health system at all? Is there anything mandated for patient peer support groups?
Yeah, it's not. And I have yet to hear of a formalized peer support group. I think people kind of figure, kind of small local things out perhaps. But the biggest one that I've heard of is your Facebook page, of course, as well as we have one that I belong to that's a bit more international, but localized in the US, that's very similar as well. And that's more for survivors and family members. Uh-huh. So the bystanders in that case may be the family members, but I don't know that it's marketed entirely to bystanders or people who help. And now I know as well you have one for chain of survival as well. So that one would be excellent for bystanders to look at as well.
Yes, Chain of Survival UK, if you're in the UK, obviously. But as Katie says, it's similar, I guess, to your bystander network, but it's on Facebook, and it's sort of like an offshoot of our main group, because we were getting quite a few partners and lifesavers join us, and they were feeling a little bit left out, really. And I think I've seen you quote it, and I've used it before, that sort of a phrase saying they're the forgotten patient, as it were.
Yeah, we just submitted a proposal for some funding as well to look at the idea of for family members, spouses and family members of cardiac arrest survivors, looking at that, what co-survivorship means. And you're just to your point about it being quite different for them, and so it's really important that they have a space that they can feel safe into.
Exactly. And do you think that includes the survivors, or do you think it works better if the survivor isn't totally involved?
I think it's good both ways. We are just finishing up a study and going to publish a paper soon where we did what we call dyad interviews, and we interviewed the survivor as well as their spouse or family member. We interviewed them together as well as we interviewed them separately. And it was very interesting to us that we actually heard very different things depending if they were together or separate. And so, and that's what led us to develop this other proposal about looking more closely at the spouse and family member experience. Because I know many of the survivors I've talked to, as they're so appreciative of their family members and their spouses, and they're, very happy to obviously have them in their lives and terrific support. But in terms of understanding each other's experience, it's really quite different. And so, trying to tease that apart a little bit.
So what sort of things did you hear that are different between the two groups?
Well, I think one of the main things is that usually the survivor, particularly someone who has had a very good outcome with no sort of, brain injury or anything like that, or loss of function, will say, I'm good, I'm great, I'm perfect, I'm back to normal, I'm back to work, everything's great. And then we speak to the spouse, or particularly the spouse, sometimes the family member, and son or daughter, and they'll say, not quite. his memory isn't what it used to be, or he fatigues easily, but he won't admit it. Things like that. So that's sometimes interesting, perspectives, and you could, unpack that tremendously from a psychological perspective for sure. One of the other things that we hear sometimes is that survivors will have a carpe diem kind of approach to their new lease on life. They realize that they died and they've been given a second chance, and so they almost have a bit of a personality change. And how you deal with that as a spouse, in particular, is interesting, because now you're living with someone who has a completely different outlook on life, and may or may not include you. And so that can be really hard to navigate. And sometimes it's positive, and sometimes it can be very difficult. So looking at some of that, and also how to kind of deal with your own concerns as a spouse or family member about it happening again. And that can be very anxiety provoking, allowing your loved one to go to the store by themselves in the first little while, or to go somewhere to the park or go for a run by themselves, and not, be panic stricken the whole time that they're going to drop somewhere and you're not going to know is a fairly common thing we hear.
I mean, one of the sort of prompters for me talking to you was an article that I saw just recently, and it was all about performing it. Well, the title was very eye-catching. Performing CPR can save someone's life. It can also cause you trauma. And and one of the quotes from you within it was, "We need to be more tuned in to supporting lay rescuers." So, how do you think we could be more tuned into them?
Yeah, I think one of the things that should be almost universal is that, and I say that this could sit within the EMS or ambulance services only because they're very well informed about what had happened on the scene. They're the first ones there. Is that some kind of follow-up or debrief, even if it's just a phone call, 24, 48 hours afterwards, and then referral to more services if needed, whatever it might be. Anything, even as simple as that, I think is what we should be doing. I think folks, and sometimes the bystanders that I've spoken to don't actually realize that they've had some impact until about 3-6 months later, when they're not sleeping well, or they can't stop thinking about the situation, but they didn't realize that it was having such an impact on their life. But at the same time, a very good colleague of mine, Paul Swindell, who is a paramedic in the Peel region here in Ontario, he's developed a follow-up model where in their particular region of the province, he follows up with everybody who was on the scene of every cardiac arrest. So he calls them, he invites them to debrief, and he has a critical incident debriefing strategy that he goes through with them, allows them to talk about their experience, and provides them with any kind of, he's not a psychologist, but provides them contact with psychologists and other mental health follow-up if they feel they need it. And that has been hugely successful. And we actually published the model about a year ago, describing what it is that he does. And we're about to publish some of the results this fall, but it's incredible the kinds of things that he has been hearing about how people feel. They're very concerned about whether or not they did it right, whether or not they did CPR right, whether or not they hurt the person. They really would love to know if it worked or not, if the person ended up surviving or not. And we know there are a lot of factors that happen in between when they get taken from the scene and whether or not they survive. But that kind of feedback, and he works through the scenario with them so that he can empower them to know that what they did was right. And that seems to go a really long way for them to be able to hear that, what you did was really important.
Yeah, I can imagine that sounds fantastic. I'm quite excited to hear the results of his study. Is this the one that's in the Peel region? Is that right? Or
Yes.
Ontario?
Yeah.
Because
Yes.
I saw that on the internet and I thought, oh, that looks interesting. So
yeah. No, he's the only one that's doing that kind of program that I've heard of in my travels. There may be others around the world, but I haven't heard particularly for the bystanders. So that is specific to bystanders and witnesses. Um, um, I'm also conscious that we've been using the term bystander, and we do use the term bystander on the website because it's a quite recognizable term internationally. But we've had a lot of discussion with my colleagues around the world about the implications of that actual word, that it actually means to stand by as opposed to do something.
Exactly, because you're anything but a bystander once you start doing CPR, aren't you?
Right. And then we also have to be conscious that there are people who witness cardiac arrest and do not respond. And so, but we have been trying to move a bit more towards using a lay responder language. But I even forget myself, as you can tell. Because it is just a bit more active.
Yeah.
So his model is called the lay responder support model.
Okay, I'll look out for that. But I did come across another study that sort of said something similar to what his findings about. I don't know if you've seen it. I'm sure you probably have. The one done in Norway by Mathieson, where he was saying that providing CPR had been emotionally challenging for all lay rescuers, and for some consequences in terms of family and work life. And he talks about the essential persistent mental reoccurrences of the incident. But people who had some sort of knowledge of a deeper understanding of what CPR does tended to experience less trauma from it. And where people have been spoken to, been sort of given a debrief, if you like, that again, that seemed to help a lot. So I think what you guys are, or what this was it Paul is doing sounds like the right sort of thing to me.
Yeah, I think it's in some areas obviously they have a lot more cardiac arrest than others, but I think it would be something that EMS services could incorporate into their offerings that would be a great community support, and certainly would encourage people to reach out and talk to someone, as opposed to sort of suffering by themselves and not really understanding what happened.
Yeah, exactly. I mean, it should be almost mandated that anyone who's sort of involved with an event should sort of have at least a debrief, and then if they further need it, maybe some sort of counselling or something.
Mm-hmm, for sure. I have a friend in colleague in New York, Sachin Agarwal. I think actually you saw him in Sweden when we were there together as well. He has a follow-up clinic for cardiac arrest survivors. And he has found that that's been tremendously helpful in terms of helping people to work through, what happens after discharge. And so it's a very similar type of philosophy, really, is that, there's no shame in needing to just even talk to someone about what a cardiac arrest is and what happened. I mean, sometimes if it's in a public setting in the moment and the guy beside you on the subway platform drops, you don't even know what it is that happened. You just know they're not breathing, and the answer to that is CPR. And many people don't even understand the differences between cardiac arrest and heart attack, for instance, or other things that might be happening. And so even in providing information, and that's part of why we built the website, is that at least it's some information giving for people about what a cardiac arrest is and why CPR works and why it's important, and those kinds of things. Trusted information, because sometimes when you Google things in the healthcare field, it can get you off onto some very nasty tangents.
It can.
So trying to provide some trusted information about what's going on. A lot of questions, not as much in Canada, because we have something called the Good Samaritan Law, and I believe the UK has it as well, where you cannot be sued for helping someone in any situation, but particularly in a cardiac arrest. But in some other countries, which are a bit more litigious, like the US, that still remains a concern as well. And so trying to debunk some of that mythology as well is really important for people.
I mean, I guess all of that sort of stuff could be part of the CPR training as well. I'm guessing that people don't get told those sort of things when they go and learn CPR. I know some sessions are only like half an hour or 40 minutes, but it does need to be perhaps put in the real world context, as you were saying earlier, a little bit more.
And I think sometimes there's a bit of fear. Some CPR trainers I've talked to about the potential to also address the fact that, you might feel traumatized after this. And some of the CPR trainers I've spoken to had been reluctant to bring that up in a training session. And I can understand that we don't want to scare people off from actually performing CPR, but I do think there's a place to talk about it in a positive way, to just make people aware that doing something like this can be very impactful, and that they should think about talking to friends and family after it happens, at the very least.
What things do you advise people to do if they come to your bystander network and they say they're experiencing nightmares or whatever? How can you help them?
Yeah, so we do have a section on the website where people can submit questions or their story, or reach out for support. And certainly we are not therapists, or we are not clinically able to help people, but we do highly recommend that they seek out help, starting with talking to friends and family, and then obviously more professional services if they need it. So that's the number one piece. We're actually just about to launch to place a thing on the website that is very clear about that it's something you should talk about, not something that you should think about by yourself on the couch. And to, if you were trained, go back and talk to your trainer about what happened. And one of the things we've also thought about starting to do is to get people who have actually done CPR in an out of hospital setting to become trainers, so that they can share that kind of real life information. As much as we love and cannot survive without our CPR trainers, many of them actually haven't responded to an out of hospital cardiac arrest in real life. And so trying to incorporate some of those folks, if they're willing, I think would be a really neat way to share that information as well.
Yeah, that sounds a great idea. In my group is a lady who actually, she's in New Zealand, not in the UK, but she actually had a cardiac arrest in a CPR training session.
Oh my goodness.
I don't know if the CPR trainer had done it on a real person before, but I know there was a little bit of a panic because the AEDs that they had were the dummy ones. They weren't a real one.
Yes. But yes, and there's a lot of that's the other thing. We talk a lot about the CPR, but there's also the AED piece as well, right? And being comfortable with that, and using those as well if they're publicly available too. So there's a lot that we assume people will be okay with, and I think we got to stop making those kinds of assumptions.
Uh-huh. With you mentioned on your bystander network website that people can submit their stories. Is there somewhere that they're publicly available? Can people, other CPR givers or lay rescuers, can read what other people's experiences have been?
Yep, definitely. So we had it up for a little while, and we just pulled it down. Actually, it was a while ago we pulled it down. We need to get it back up. We were trying to find a better way to make them available. So we're trying to figure out a more visually appealing way. We had them in sort of a scrolling system, and that was making it hard to read. And so I'm just trying to work with our web designers. But yes, so they will be available for people. And that was the idea, is that, by sharing stories that we can see ourselves in others and share our experience.
Yeah, I think that's very powerful, because I know there's a lot of people in my group who just read other people's stories, and they get a lot of comfort from that. So just sharing helps a lot.
Definitely, yeah. And it's I think there's a lot to be said for storytelling, and many of the folks that I've talked to said that once they met someone, whether it be another survivor or another bystander, it sort of everything changed for them, and they were very, very happy and felt that was really a helpful thing. So I'm sure you must hear that among your members as well.
And indeed, a lot. Yeah. When I first arranged a meetup, which is like 4 years ago now, that it was a very small group, and there was roughly half and half in survivors and lay rescuers, and we sort of naturally just sort of paired off in the survivors and the rescuers, and afterwards my wife said, it made her feel a bit more normalized the situation of all the experiences and feelings that she was going through. So, and I've heard that so many more times since then. So yeah, you're dead right. And that one of the things I should always do a plug for it, but in a couple of weeks' time we've got a big meetup at the end of in Rutland, which is in the middle of England, and we've got over 100 people attending that, which is survivors and lifesavers, and hopefully we were going to have a session where people can peel off, and survivors can chat with other survivors, and rescuers can chat with other rescuers. So hopefully a lot of that will be going on. Yeah,
that's wonderful. Yeah, it's amazing to me. I would say like 95% of the survivors that I talk to have never met another survivor. And so it's so good to have these opportunities for people to connect. And so I would say the bystander is probably about the same. It's quite high that they don't in their day-to-day life don't interact with someone who has also responded. And so it's really important to and even the health. There is obviously a group of healthcare providers who may be off duty or on vacation or whatever that end up witnessing these things as well, but their training in their situation is quite different. And so, they can still have trauma, but their ability to deal with that can sometimes be a bit different. And so, it's interesting from that. So even talking to other healthcare professionals isn't always enough.
Okay. So where do you see the sort of we're going to go in the next couple of years with regards to lay rescuers? Sorry. What can happen? How can we make things better for them across the world, as it were?
Yeah, well, I think that I think we could make great strides in like I said, in improving how we train people and incorporating some of that psychology into it. Again, not to scare people off, but to empower them and give them the tools that they need to actually be strong responders. I think that's huge. And then on the flip side, making models like Paul's more widespread, having that be the norm or mandatory, as you mentioned, something that we do for people. Because I think I was talking to Richard Price, who's the founder of PulsePoint, the PulsePoint app that crowdsources help for cardiac arrest. And he said he always has felt a bit bad about calling people to action and then not actually providing anything for them afterwards. And so I think that's kind of what we need to keep in mind, is that we owe these people something for their tremendous heroism. And so, I would like to see that, us move in that direction as well. And then certainly, resources like the Bystander Network or the Chain of Survival Facebook page and things like that to develop to a point where they're fairly commonly known within the community, and they're already quite easily accessed through the internet. But that's if it's nothing else but to I've been talking to a few of our EMS agencies about even just handing out a business card that has the website on it, because obviously there's a lot going on at the scene. But if it's as simple as just a single message that sends somebody somewhere where they can get some help, I think that could be something we could easily do in the next couple of years.
It's been a really fascinating 50 minutes of your time. So I really thank you for all of that. And hopefully there are going to be a few more studies and to prove the problems that lay rescuers have after cardiac arrest, not after doing CPR, sorry. And things, or the powers that will start to put these things into action, especially in the sort of training of CPR, because I think that's the sort of the obvious point to sort of put it in, really, to teach people up to start with. So I thank you very much, Katie, and hopefully we'll get to chat again soon, and I might meet you at another conference, who knows.
Yeah, no, that would be great. Thank you very much. I really appreciate your support for the Bystander Support Network, and thank you for all the work that you do with the Survivor group as well. It's incredible, and I look forward to seeing you soon.
Okay, thanks a lot. Bye-bye.